hamstring muscles. So I'm going to do short head of biceps femoris. So this is a good muscle in patients who have foot drop. And biceps femoris short head is innervated by the sciatic nerve, but mostly the fibular distribution of the fibular division of the sciatic nerve. So if you're trying to differentiate a perineal neuropathy or fibular neuropathy from a more proximal process like a sciatic or L5 radiculopathy, this is a good muscle. Sometimes we see, in particularly radiculopathies, you'll see sparing of some muscles in a myotome. So if someone has a very weak, has a severe foot drop, and you put your needle in this muscle and there's nothing going on, I think you're pretty safe at saying that this is not something more proximal than the fibular nerve. There may be, depending on what you read, some people dispute the L5 predominant innervation of the short head of the biceps femoris, but in my practice, I've found that it's involved when it should be, and it's not involved when it shouldn't be. So I don't know.
So you're saying it's more L5 than S1?
Yeah, it's more. It has some S1 in it, but it's more L5. It's mostly L5, I think. So for this one, can I have you roll on your side and face this way? So I'll have the patient positioned on their side and have their leg bent at 90 degrees. And so what you're feeling for is the tendon of the long head of the biceps femoris, and that comes laterally here. So have you push back, push your knee back or leg back against my hand here, and then so you can see it pop out right there. So you're going to go about 3 finger breaths proximally from the popliteal fossa, and you're going to go just medial. Can you bend your leg back again? Yeah. So just medial to that tendon. You're right there. Okay, you're going to feel the poke. To activate, then you bend your leg back against me. It's a little too much activation, and then I like, but that's the basic procedure doing this one. So again, I like this muscle because it's an L5 muscle that's above the fibular nerve.